So I'm presenting the case of a 74-year-old female from Vamanjur, who's a homemaker by occupation and has studied up to 6th grade. She presents with complaints of swelling over the right groin region since 6 years. So patient who's a known case of asthma and hypertension since 7 years, presented with a swelling over the right groin region, first noticed 6 years ago, which was insidious in onset, gradually progressed from initial small size of around 1.5 centimeter to 1.5 centimeter to current size of around 6 centimeter to 6 centimeter. The swelling increases in size on standing up, walking, and coughing, and decreases in size immediately on lying down. There is no history of pain, no history of nausea or vomiting, no history of constipation or obstipation, no history of abdominal distension, no history of straining during micturition, no history of change in frequency of the micturition, and no history of prolonged heavy work. Her medical history shows she's a known case of hypertension since 7 years, and she's currently on telmisartan. She's a known case of asthma since 7 years, currently on inhaler medications. She's not a known case of diabetes mellitus, tuberculosis, or hypothyroidism. So patient also underwent a left-sided inguinal hernia repair 8 years ago. There's no similar complaints in the family. Her diet is mixed. She has a normal appetite. Her sleep is undisturbed, and her bowel and bladder habits are regular and unaltered. There is no smoking, alcohol, or substance abuse history. Her obstetric index is P6L3A0E0, and all her deliveries were normal vaginal deliveries and uncomplicated. So to summarize, patient is a 74-year-old female patient who is a known case of asthma and hypertension since 7 years and is previously operated for left-sided hernia of the groin 8 years ago. Presents with complaints of swelling over the right groin region, which reduces immediately on lying down and increases on standing and coughing. Yes, sir.
Good, very good, Dhruv. Good presentation. Okay, be a little more louder. Okay, and little
Yes,
slow.
yes. Yes.
Okay. So, Dhruv, okay, in the first slide, you have asked about the age of, okay, Nishanth is that. Okay, Nishanth, you can start. You can start.
No, please start off and I'll join in between.
No, it's okay. You start.
Okay, Dhruv, starting with the age, what do you think is the importance of age in your particular case?
Sir, since this is an elderly patient, she's more likely to go for like in case of hernia, this is a hernia case, so she's more likely to go through a direct hernia than a indirect hernia due to weak abdominal muscles.
Fair enough. And with regards to the sex, which gender do you think is more prone for developing a hernia?
So males develop hernia more frequently, but in inguinal hernia is most common in female.
Okay.
Yes.
Why do you think males are more common or more predominant for developing a hernia?
Sir, mainly based on the etiology of the hernia. So men are more prone for COPD. Men are maybe more physical activity could lead to a rupture in the abdominal walls that could lead to hernia as well, which is of acute onset.
No, Dhruv. Okay, no, maybe partially right. What is interested is what is the peculiarity? What is the main difference between the male and female anatomy, which can predispose to have more incidence of inguinal hernia in males than females.
So the spermatic cord is the content of them.
That's all. Because
already there is a weakness. There is already weakness. Okay.
Yes.
So what other peculiarities you know about female inguinal hernia?
So
inguinal canal. What is the peculiarity or what is the how it's different from males?
So the content is round ligament of uterus in case of females. And the processus vaginalis is called the canal of Nuck, and it's a separate structure that passes through the canal.
No. Anything else? Not about the structures. So the inguinal canal in females is very narrow and very short. Okay, almost superficial and deep linkage overlies. There is no separate inguinal canal as such in females. Okay, so it's very narrow. So the incidence of hernia is also very less comparatively. Understood?
Yes,
So,
yes.
the protective mechanism is more that closing of the deep ring and all, it's more predominant in females than the males. Not just the
Yes.
etiology. Now the males also smoke, females also smoke. Both does heavy work. Everything is there. Even females have more increased abdominal pressure because of pregnancy and all there. That is secondary. What he was interested to ask, see, you should listen to examiner what is interested in asking, then answer.
Yes, sir.
Okay, okay, Nishanth.
Yeah, and now next with regards to the occupation. Why do you
Yes,
think
sir.
that's important?
Sir, again, strenuous work, if there is in her occupation, then
happens?
that could lead to
What happens?
a weakening of the muscle wall in case there's a
How?
tear.
Okay, Dhruv, one
It
simple
can,
question. Do you go to the gym?
not much, but yes,
Okay,
yes,
so why do you go to the gym? To tear the muscle or to strengthen your muscle?
to strengthen.
So why that there you're giving one reason, here the other reason?
Sir, if it's very strenuous, then it could lead to.
I'm telling you it's not very strenuous. What else happens? When all your abdominal muscles contract, what happens to the pressure inside the abdomen?
Increases, sir.
So what happens when the pressure increases? It tries to
So
force the contents outside, right?
yes, yes,
Yeah, that is the reason why the hernia happens. Don't be set on the fact that just because they work out, they'll have a muscular tear and they'll end up with a hernia.
yes,
Okay? Yeah.
yes.
Kishan, anything else in this slide?
No, next.
Yeah, please move ahead through.
So should I?
You can go ahead. Any thing about the duration?
So since it's a very long duration, it could most likely be a direct hernia itself, since they're less prone to go for complications.
Not necessarily, but I do accept your answer. One question, why do you think that the direct hernia has a lesser risk of complication as compared to indirect?
So it's a broader base. It's not going through a narrow ring as it does in indirect hernia. So
Okay,
the chances of obstruction or strangulation and all is much lesser.
fair enough. And can you tell me another important difference between the direct and an indirect hernia?
Direct one in it happens in elderly age group due to weaker muscle tone
With regards
and
to the anatomy and the
so it occurs medially to the
that is different. If a patient comes with a swelling which has gone up to the scrotum versus a patient who says the swelling is not gone into the scrotum.
yes, so then if it's not gone into the scrotum, then it's a direct hernia more likely.
Why do you think that happens? Why can't a direct hernia go to the scrotum or go to the base of the scrotum?
So there's no connection to the
Why?
into the scrotum. There's a the so all the aponeurosis would come in between. They wouldn't be able to go through.
Anyone else? Raghav is there. Raghav, I have unmuted you. If something, Dhruv, if he can't answer, where is Raghav? Raghav is left. Huh? Raghav is there. Raghav, are you there? Or anybody in the any audience can answer. Unmute and answer. Okay. Say one more thing, Dhruv here. The duration, what Nishanth was asking. If it's there since
Yes,
long time, means what the common sense say? What do you understand by that? It's uncomplicated. It is not causing
yes,
any symptoms or it's not causing any problem to the patient.
yes,
You understand?
yes,
In 6 years, it's there means it's only you understand that it's not complicated hernia. It's not causing any kind of problem to her.
yes,
That's what a examiner is interested to know. If it is there since the hernia is there since 1 week and she has come to you, that means it's troubling her.
yes,
Mostly in the inguinal hernia or femoral hernia in ladies, they come with complications straight away. Okay, the
yes,
more chance, just like you mentioned, anatomy, it's very narrow and this thing, so they end up getting complicated. So they may present with complications. So what Nishanth was asking about the duration, long duration means what you should be answering is, sir, it is uncomplicated hernia. It is not causing her any problem. That's why she's come late. That may be the better answer. Nishant,
Yes.
your internet okay? Huh?
Yes, excellent. Just one, I think I zoned out a bit with the network issue. Dhruv, the other point what I want to tell you was that in a direct hernia, the reason why it doesn't go into the scrotum is because there is something called as a fascia transversalis,
Yes, yes.
which prevents it. Whereas an indirect hernia goes through a defect through the fascia transversalis, so it has
Yes.
a direct access. Okay,
Yes.
that's the reason direct hernia doesn't reach the base of the scrotum.
Yes.
Go on. Please move on to the next slide. Okay. For future reference, why have you started off with asthma and hypertension and then gone on for to give the rest of the history? Don't you think you should first give the main chunk first, or the reason what has happened?
Yes, sir. Yes, sir.
So
No,
for
not
future,
yes. You tell why you written like
yeah.
that. Tell. You don't need to
So I've
like.
written so asthma basically could be a risk factor for the development of a hernia. So I've mentioned it as something that has to be presented initially itself. And since she's currently undergoing treatment for asthma, so thought I could mention it under
How
history
asthma
of
can
it.
lead to you'd be
So
thinking
increased
that way.
intra-abdominal pressures.
How? Some people still doesn't understand that. You tell
So
me.
during coughing, it could lead to
Chronic cough. Still lead to
chronic
chronic
cough.
cough. That can lead
Yes.
to, okay, make it simple.
Yes.
Any
Yes.
asthma patient may have chronic cough that can increase the intra-abdominal pressure that may cause. So you are giving a clue to the examiner in the beginning itself. See, my patient is having asthma that might have predisposed to the inguinal swelling, like hernia. Okay.
Yes.
Okay, Dhruv, I just have one contradiction to that statement. I have read the
Yes.
PPT. I have saw you have immediately written next side. The minute she takes inhalers, the cough subsides. That means the cough is not that bad.
Yes.
Okay. So don't
Yes.
put it up in the starting. It is a part of HOPI. I am not saying no, but don't
Hmm.
start with that.
Yes. Yes.
Okay. This
Yes.
looks like as if the asthma is the one which has led to the hernia. No.
Yes.
Okay, because this lady also had a hernia on the opposite side, right? That time, what was the cause?
Yes. Not.
Correct. So
Yes.
start off with the proper way. Like there was a swelling and the rest of it is fine. That is a swelling in the right groin, first noticed 6 years ago, all that is fine.
Yes.
Put the asthma and hypertension probably at the end of the HOPA.
Yes.
Can you
Okay.
tell me the connection between hypertension and hernia in any way?
Sir, hypertension I put mainly since she's taking antihypertensives. If this patient is to be operated,
No.
then it
You're telling no. That's later. Now connection between any causation of hernia and hypertension. Any logic or anything you can connect between what chronic hypertension can lead to? Think. I'm just making you think. What happens to the vessel size? What happened to the blood flow?
so there'll be thrombosis and
Not thrombosis. Gradual ischemia can this thing, no?
Yes.
Ischemia, so muscle weakness can happen.
Yes, sir.
Okay, so you can see now you already committed there. So examiner is telling it's not relevant at all. Okay, then how you can substantiate yourself is okay. Something means
I accept your answer where you actually said that if you are planning for surgery, yes, you
Yes.
need to know what is the hypertensive status of the patient. So like I said, you would rather have the examiner concentrate on the hernia rather than concentrate on asthma and hypertension because they know you have not studied about it.
Yes.
Okay, so don't get into that junket. Okay.
Yes.
Yeah. So the rest of it is quite okay, saying that the size was small, then gradually increased. So was the swelling associated with any sort of okay? Last one. You have said that it increases on standing up, walking, coughing, and decreases in size immediately on lying down. At any
Yes.
point of time, did she have to manually push it back?
No, sir.
No. Even now, it goes back by itself.
It goes back by itself.
So why do you think that she's come to you now? That if it's not troubled her for 6 years and the same thing is happening, why has she come to you now?
Sir, it was a reference case, I think, from a different. I'm not really sure, sir.
Okay. Was there any pain associated with the swelling?
But there was no pain, sir.
If there is pain, what are the types of pain do you expect in such a patient?
So one could be So it could be if it undergoes a strangulation, it will be a severe pain.
First,
And
simple.
if it,
Simple.
First is
Yeah.
in
reducible.
most
Uncomplicated
so
hernia.
it could be a mesenteric stretch or
So where
so
will be the
that could
pain?
lead. The pain would be around the umbilicus.
Type.
So it's a referred pain usually.
Okay.
Type. The nature
Type
of
of
the
pain.
pain.
Dull aching.
No.
So
Throbbing.
dragging types.
What is drag of the mesentery?
Mesentery, yes.
Okay, because mesentery is fixed. Okay, so when the intestine comes out, there's a pull of the mesentery that causes any midgut structures. So it will be pain around the umbilicus. Okay. Then
I was just
Yes.
about to ask you, Dhruv, why not in hypogastrium? Why not in epigastrium? Why only umbilical? Hernia is in the groin, right? So isn't hypogastrium closer? Or isn't right iliac fossa closer?
So the referred pain, so the nerve supply would be
This is not a case of referred pain. See, the whole idea is, do you think mesentery has somatic nervous system?
no, sir.
It only has autonomic nervous system, right?
Yes, yes.
So remember that anywhere in the abdomen, if you have autonomic nervous system, it is always in the midline.
Okay, sir.
And in the abdomen, you have foregut, you have midgut, and you have hindgut.
Yes.
Okay. So any structure or any problem associated with the foregut, the pain will initially be in the epigastrium. Then once it becomes somatic or once the inflammation comes out and involves the parietal peritoneum, then it goes to that particular site. With
Yes.
the midgut, it's in and around the umbilicus, then goes to that particular site. So now we'll just take a small pause here. What is the typical presentation of a patient with appendicitis?
So it'd be a migrating pain now.
Why do you think the pain goes from umbilicus to the right iliac fossa?
Yes.
Correct? It's a midgut structure, right?
Yes.
So that's the reason initially the pain is in the umbilicus, even before the inflammation has come out of the appendix. Once
Yes.
it comes outside the appendix and it involves the parietal peritoneum in the right iliac fossa, then the patient will start having pain in the right iliac fossa.
Yes.
Okay. So same thing, any problem associated with the hind gut, the pain will be in the hypogastrium. That's the reason why the initial pain will be in the umbilicus. Now I'm saying the patient is having pain in the right iliac fossa or wherever the hernia is, but it is not a strangulated hernia. Why do you think the pain is coming?
So pain in the right iliac fossa, but it's
In the
not a
groin.
strangulated.
In the groin region, lingual region.
Yes,
Sir,
inguinal
if
region,
it's
the pain.
in case of indirect hernia, we can say if it's due to the stretch of the internal lingual ring.
Muscle, stretch of the muscle.
Yes.
So if patient complains of pain in the umbilicus, then you know it's a mesenteric stretch. If the patient is complaining of local pain in that particular groin, that means it's because of a stretch of the muscle.
Yes.
Okay. Now, if the patient says, here she said it went back in immediately without doing anything.
Yes.
But if the patient says, no, there is difficulty, they had to push it or it is stuck, what do you think are the possibilities?
So it could just be a irreducible hernia.
Okay, and next?
So if I go in that order, it'll go to irreducibility, then it can go to incarceration between, then it can go to obstruction and then strangulation.
Fair enough. We'll get into that as and when we get into treatment. So, Kishan,
Yes.
any other questions on this slide?
No.
Yeah, move ahead. Let's try and finish
What
off.
other, now you didn't complete his question. What other all the types of pain he was asking with presentation? One is okay, dragging type of pain and this dull aching type of pain when the stretch of the muscle. Then what other types of pain? Sudden severe onset of
Sudden
pain.
severe in case of strangulations.
Obstruction
Yes.
followed by strangulation. You will have that.
Yes.
Okay. Yeah, next slide. No history of pain. Why nausea or vomiting?
Sir, in case of obstruction, they could present with a continuous vomiting.
Fair enough. Constipation or obstipation, also same thing. Abdominal distension, also I can understand.
Yes.
Why have you asked for straining during micturition?
Sir, in case there's a cystocele, in case of a female patient, could lead to
Cystocele, do you think they'll come with straining during micturition or they'll come with a mass in the vagina?
Some mass in the vagina, there'd be a difficulty in micturition or voiding
No, but
of
what do you
urine.
think will be the primary symptom? For 6 years, if she sat with the inguinal hernia, she would have even sat with this one also, right?
Yes.
Hmm. So straining during micturition doesn't apply too much for a female. Okay, it's more for males.
Yes.
And can you tell me why?
So in case of BPH in males, there would be
In an elderly
uh,
patient,
in an elderly patient, there could
what
be
about a
BPH.
young patient?
So it would be strictures more likely.
What do you think is the most common cause of a stricture?
So STIs,
Hey. No, that's not
uh,
the most common. It's one of the reasons. I agree.
so then catheterization is frequent in
Correct.
Any
It is
instrument?
always iatrogenic.
yes.
Okay, some sort of instrumentation, catheterization. So you can also add, if you want, saying no history of hospitalizations. But that's like I said, that's only for males. Don't get into that janjat with females. Okay.
Yes.
If I ask you to differentiate between a BPH difficulty in micturition versus a stricture difficulty in micturition on history, can you
So
differentiate the two?
BPH, the voiding would reduce on straining. So,
Okay.
and then in case of stricture, the stream would probably be faster and thinner.
Excellent answer. Can you care to explain why that happens?
So in BPH, the bladder gets compressed over the prostate thing. So the opening is kind of obstructed in case of straining. And in case of strictures, since there is the opening becomes tinier, so the stream would be thinner, and in a thinner opening, the stream would increase in speed.
No. Okay, so what happens in BPH is the more and more they put pressure, the bladder tends to overhang on either side of the prostate.
Yes, sir.
Okay, so once it overhangs, the urine in these two pouches will never empty. So
Yes,
the more he strains, the urine keeps on going into the side pouch rather than through the prostate in the center.
yes, sir.
Okay, that's the reason the more they strain, the less is the urine that comes out. And there will be increased frequency. They'll feel like constantly the bladder is full. So they have to
Yes, sir.
keep coming back.
Residual.
Whereas the stricture urethra, it doesn't overhang because the problem is much further down in the urethra, not in the prostate. So here
Yes,
the bladder will be able to empty, but like you said, the more pressure they put, it kind of jets out like a rocket. Okay, the stream will be.
I think again has got internet issues. Anyway, Dhruv, next prolonged heavy work. Why you have asked?
so same. So in case of increase intra-abdominal pressure could
Okay.
be there.
Next slide. Nishant, okay. You
Yeah.
are stuck. You are, can you complete that? What you're telling? Nishant?
Most common causative organism I asked, then I think I kind of lost you
Yeah.
guys.
Of
So
most common
of
positive factor for
STI.
STI.
okay. So it could be syphilis.
No, in this case, causing.
Then
Somebody's given the answer. See,
Or
so HPV
urethritis.
infections.
it's gonococcus. Okay, gonorrhea.
Gonococcal urethritis.
Yes.
Okay.
Excellent
Yes.
answer, Raghav. Yeah.
Next.
Known case of asthma. Why diabetes, tuberculosis, hypothyroidism?
So in case of diabetes, I've asked for mainly the again the treatment in case of
No, he's
surgery.
asking
we
about
need to do some
hypothyroidism.
surgery.
Only.
Hypothyroidism, I've asked so since like in case of hypothyroidism, there's a decreased muscle tone, which could again lead to possibly a hernia in case of severe hypothyroidism.
No. Is there something like that? I wasn't aware of it.
It's something I've heard of, so not sure.
Somebody is okay. AK has said hypothyroidism can lead to constipation that can cause increased training. Yes, but
Yes.
don't get into this. Preferable to avoid all that. Okay. If it is
Yes.
there, you mention like hyper or
Yes.
hypothyroidism is there. Please mention because it becomes a very important factor when you're operating. If the thyroid
Yes.
status is not corrected, in what will happen if you operate on a patient with hypothyroidism? What will happen if you operate on a patient with hyperthyroidism?
Sir, and Hypo, it could lead, in hyper, it could lead to thyrotoxic shock, thyroid storm.
Storm. Okay.
And in hypo, myxedema coma.
Right. They don't get out of the anesthesia.
Okay, so
Okay?
yes.
Because the metabolism, everything is come down once the anesthesia gets into the
Muscle
body.
relaxation.
Yeah.
is stayed.
For it to
Yes.
get out, it doesn't get out because the metabolism is that much slower. So you will
Yes.
have to take consent for prolonged intubation, ventilation, all these. All right?
Yes.
Done. Now you have said underwent left-sided inguinal hernia repair 8 years back. What is the significance of this?
Sir, it's sir, I've asked since there's a chance, there's like around a 33% chance, I think, that a hernia on one side, if a patient has a hernia on one side, it occurs on the other side.
I think it's about
And
10%, but that is not the idea. Now the patient has already come with this, right?
Yes, sir. It indicates like probably a poor muscle tone in this patient.
Correct. Some
That
sort of
he's having
muscular
difficulty.
problem, some collagen vascular disease, all this you should keep in
Yes.
mind. But
Yes.
what goes against the point that it could be a collagen vascular disease?
There's no family history.
No, something else. I do agree, but something else.
One has come 8 years ago and another side is coming now.
And second point, Dhruv, the collagen vascular disease is a congenital problem or an acquired problem?
So it's a congenital problem.
Correct. So if it's a
Earlier
congenital
diagnosis.
problem, when do you expect them to present to you with a hernia?
In a younger age group. So
So what is the age of this patient?
70. Yes, sir.
Okay, so unlikely to be collagen vascular disease.
Yes.
Any other important surgical history?
So if we'd ask about appendicectomies.
Why?
So since like during the muscle cutting incision, there could be damage to the motor branch of ilioinguinal nerve that could lead to poor muscle tone.
Okay. Now, let us say I'm operating an inguinal hernia. And what are the
Yes.
contents of the inguinal canal? Sorry, can you just tell me quickly? Two main contents.
So the ilioinguinal nerve and the spermatocord in males, and in females, it's the round ligament of uterus.
Fair enough. If I cut the ilioinguinal nerve there,
No, sir, it doesn't lead to
why?
hernia form because it's only the sensory branch once it enters into the deep brain.
Excellent. So
Already
what
given
is it,
the
what
muscle.
is the sensation that is lost?
So the medial part of the thigh and the above around the pubic tubercle, that area is sensations
Medial
are
aspect
lost.
of the scrotum and the upper part of the thigh. Okay, that is
Yes.
when they'll have hypoesthesia.
Yes.
Excellent. So this was for a open appendicectomy. Yeah,
Yes.
done. I don't think I have any extra questions. Kishan, any extra questions from your
That is
side?
a very good question. They'll try to answer. All the examiners expect you to know this. Okay, the inguinal nerve and the whatever you told is perfect. It gives the branch to the muscle, and then only it enters the canal. And okay, so if you injure the nerve in the canal, nothing happens. In fact, many surgeons they cut the ilioinguinal nerve with the scissors to avoid getting trapped inside the mesh and all. They correct, Nishanth. Okay, the hypostasis is better than the
Inguinodynia.
inguinodynia.
Yes.
So many people cut it. There is so many studies also cutting versus non-cutting. Okay, so what you should know is whatever it happens, the muscle weakness, if it is injured before entering the inguinal canal, not after the. How the examiners trick you is by asking like this, what Nishanth asked, or they ask if there is a inguinal abscess was there. One intern or PG was draining the inguinal abscess and then the inguinal nerve was cut. So is there any chance of developing into inguinal hernia in the future? They ask you. No. Okay. No. Oh, good.
Yeah.
Next.
There share similar complaints in the family.
Yeah, that we have covered.
Yes.
Bowel bladder habits. Okay. Yeah, let's not get into the same thing. Bowel bladder, I think we already know we are more worried about constipation or obstipation. And in bladder,
Yes.
we're
Hello, sir.
Yeah. How smoking can result in? Is there any role of smoking in hernia?
Yes, sir. And
You told,
mainly in two ways. So in case of like smoking could lead to COPD, one that could lead to increase in abdominal pressure due to constant coughing,
one.
or
No,
it can
what
also
I asked
cause
is,
collagen.
Is there any role of smoking?
Collagen
cause
synthesis
hernia?
also can get impaired.
Sorry,
Hello?
you answer again for the sake of Nishanth. He got. stuck.
Yes, sir.
What is
Yes,
the
sir. So
role of
smoking,
smoking and hernia?
so it could lead to like collagen synthesis could be impaired due to smoking, which is one, and then it can also lead to COPD, which would increase the intra-abdominal pressure.
Okay, good.
Yeah.
Next.
So what exactly happens with smoking and collagen synthesis? Any idea?
So that alpha-1 collagen is impaired, I think. I'm not very sure what
There is
happens.
something called elastase. That elastase increases
Yes.
in smokers. So breakdown of collagen is more rather than collagen synthesis.
Yes.
Okay. Done. And same thing with what about alcohol?
So it'll a long shot, sir, but if it can cause cirrhosis and ascites, that is one.
Done.
Then-
Fair enough. I'll give it to you.
Yes.
Next. Done. Any comments about this? Her obstetric history.
So, since like she's a grand multipara, so continuous stretching of the abdominal wall plus like pregnancy induced, there is decreased like strength of ligaments due to hormonal changes. So that could also be a
Yeah.
precipitating
Repeated
factor.
stretching can lead to weakness of the abdominal wall.
Yes.
Yes.
What other common condition she may get? What other common surgical condition she may be predisposed to?
So prolapse maybe.
Okay, prolapse then. In
Uh,
surgical condition, anything?
General surgical condition. That's what he meant, not OBG surgical condition.
so diverification of recti.
Okay, then
Then so
it's
if,
quite
if there was cesarean, then fan and steel incision, they could present with
incisional
many
hernia. Okay,
conditions.
other than hernia, or then in the
No,
lower
so-
limbs, anything.
So it's varicose veins.
Okay, next.
Yes.
Okay, summary is
So-
fine. So at the end
Yeah.
of the summary, what do you feel?
So it's right groin hernia, which is reducible.
Why you think it's a hernia in the history?
So due to its expansile cough impulse and
No, you've not gone there to cough
Some
impulse.
in the history.
is
Look at
so
your summary
there
and
are
answer.
Huh? In
Go on.
history, what makes you feel that it is a hernia? One point you written at the end.
so it increases on standing and coughing and decreases on
Now,
lying.
this is spelling is
So
which is
reducibility
reducible.
and yes, reducibility and increase in coughing.
Okay. Any other swelling in the groin may not decrease on like okay.
Yes.
Okay. Then anything, Nishanth, you want to add? That's
That's
it.
it. Nothing else. Nothing else. He can move on to the examination. So we can have a little bit about treatment also.
Okay.
So general survey, the consent was taken, patient was examined in a well-lit room and exposed some
Okay. Go to
Cepheid to
the
knee.
local examination.
Yes. Patient was examined in standing and lying down position. On inspection, a solitary globular swelling of size around 6 into 6 centimeters situated in the right inguinal region. Skin over the swelling appears normal. There's no dilated veins, no visible peristalsis. Expansile cough impulse was visible. Swelling reduces immediately on lying down. On palpation, there's no local rise in temperature and no tenderness. Right inguinal region, so the site is the right inguinal region above and medial to the pubic tubercle. Size is of around 6 into 6 centimeters. Shape is globular. The swelling was manually reducible with no gurgling sounds on reduction. Expansile cough impulse was felt. The swelling was doughy in consistency, and on deepening occlusion test, swelling was seen medial to the site of occlusion on coughing. And on Zeeman test, the impulse was felt maximally on the middle finger. On percussion, a dull note was heard over the swelling, and on auscultation, there's no bowel sounds heard. On inspection of the left inguinal region, you could see a single linear scar present parallel to the left inguinal ligament, around 4 centimeters in length. There's no visible swellings, no cough impulse was felt on the left side. On per vaginal examination and per rectal examination was not performed. Systemic, so the abdomen was soft, non-tender with inverted umbilicus. There's no Malgigny bulgings or diverification of recti on Carnet testing. Then the normal bowel sounds were heard. There's no visible peristalsis. normal vesicular breath sounds were heard on respiratory. Cardiovascular, the S1 and S2 heard was normal, and there's no added heart sounds. On CNS examination, no focal neurological deficits, and on lymph node examination, the inguinal lymph nodes were not palpable. So the summary is the patient is a 74-year-old known asthmatic, right inguinal hernia of around 6 into 6 centimeter in size, which was doughy in consistency, suggestive of momentum as content. The swelling was found to be reducible and showed bulging medial to the site of occlusion on coughing in deep ring occlusion test, and maximal palpable impulse felt on the middle finger during the Zeeman ring test, both suggestive of direct inguinal hernia. Should I?
Yeah.
Finish off, then we'll go there.
So the provision. So I should. Hello.
Tell the provision that.
Tell.
So patient has a right-sided reducible direct inguinal hernia with omentum as content and PM3 according to the European Hernia Society classification.
Done. Can you go back to the start of the local examination, please?
Yes.
For future reference, in a hernia, do you expect any skin changes or dilated veins?
So skin changes in case of a strangulated hernia, it could lead to.
Simple question. Will you get a case of strangulated hernia in your exam?
No, sir.
And do you know how long it will take for a strangulated hernia to cause skin changes? By the time the patient will be dead.
Sir.
A better answer would be Dhruv. See, already in the history, she has told you, right? It's a swelling decreases on the
Yes.
side on the lying down. Then it's still strangulated or obstructed hernia or irreducible hernia.
So it will be reducible.
Okay. And second thing, where will you find dilated veins over the skin?
Sir, in case.
You don't. Otherwise, I won't have asked this question.
Yes.
All these are part of proforma, but you have to apply where it's really required. Okay.
Yes.
Proforma, there are 8-9 points on inspection, but in the abdomen examination. Okay, but whether it's really required in this case, it's applicable in my case in any way, you have to think and then ink. Think before you ink. Okay.
Yes.
Okay.
Yes.
And the whole idea is never start with negative history.
Yes.
Okay? Like, see, expansile cough impulse. See, a whole idea of a case presentation is to convey to the examiner what is the diagnosis. So why do you want to start? If you say cough impulse, that is the first thing which will tell me it's a hernia.
Yes.
So that should be your first point.
Yes.
Okay, like immediately after you say swelling of size 6 into 6 centimeters, situated in the right inguinal region. All this, I understand. But then don't put these skin changes. I would have preferably not even put it there at all. But if you want to, it has to come at the end of your inspection. Or if that's how you're being taught in the college also, if they mention that you have to mention it, please put it at the end, not in the starting.
Yes.
Okay, swelling reduced immediately on lying down. All this is fine. Expansile cough impulse was visible. Okay. Next.
Can you define cough impulse?
Yeah.
Sir, it's a expansile increase in the size of the swelling during coughing.
Need not be expansile only all the time. Many types of cough impulses are there. It is a momentary increase. See, definition.
Momentary, yes.
It's a momentary increase in the size of the swelling or momentary bulge. If there is swelling already there, it will increase in the size. Or swelling is not there, there is momentary bulge is seen with the act of coughing. With every act of coughing, there is a momentary bulge or momentary increase in the already existing swelling is called cough impulse. In case of hernia, you may get expansile. There are other types of, where else you get cough impulse? Tell me.
Sir, meningocele, then laryngocele, empyema necessitans, then encephalocele, then if a dermoid cyst has any intracavitary.
You're only talking about expansile. You wanted to talk about non-expansile cough impulse.
In groin only, see, you told, okay, what you told is anything arising from a cavity will give rise to cough impulse, right? In groin only, there are 4 to 5 conditions which will give rise to cough impulse. Can you please enlist them?
Sir, hernias, so there could be a
indirect hernia, femoral hernia.
Then femoral hernia, then saphenavarics.
Okay, saphenavarics.
Then any dermoid cyst in the region.
No. Another 2. We were just discussed in when you obstetric history.
Incisional hernias. Then,
After that, I asked you one question. What else you look for?
so it's
Grand multipara, what else thing you look for? I asked you.
yes, sir. It's
What is that? What they can have? Prone for after multiple pregnancy. What you answered? Morris says cough impulse test you do in which condition?
yes, sir. In case of in varicose veins, if there is a
Varicose vein.
saphenofemoral incomplete.
Okay. Then one more in males, you can get one more condition. In the scrotum.
Varicose seals.
In varicose seal and what type of cough impulse you get?
So reduces on. Okay.
Not reduce, it's thrill-like.
Thrill,
Thrill-like
yes.
cough impulse. Okay.
Yes, sir. Yes.
So there are types are there, and in intestine is a content. It is expansile and propulsive type. Okay, in saphana varix and all, it's just expansile type. Okay, so many types. So understood the definition, right?
Yes, sir.
Okay, Nishanth, anything else?
That's it, nothing else.
No, go to palpation. Palpation is important.
And Dhruv, for future reference, whenever you're writing palpation, it should be in a paragraph. You can't say like site so and so, size so and so, shape so and so. Don't do that.
Yes.
Okay. Yeah.
Yes, sir.
So you said something that it's above and medial to the pubic tubercle. What is its importance? So what is the relevance?
Sir, it's to differentiate if it's an inguinal or a femoral hernia. So a femoral hernia would be below and lateral to the pubic tubercle, and the swelling would be seen below and lateral. And in case of inguinal hernias, it would be above and medial.
Okay. Just to tickle your mind a little bit more. When you know it's a 6 into 6 centimeter swelling, do you think a femoral hernia can become that big?
No, sir. It would probably go to a strangulation.
Correct. And
Yes,
second thing is, what else is peculiar about femoral hernia?
So it's a retort shaped swelling.
Right. Why is it a retort shape? What do you mean by retort?
So it's a retort was like it's the lab instrument that is used in chemistry. So it's like it goes down and then comes back up. It's due to the presence of Holden's line. So the swelling is not able to go beneath the.
Correct. So it goes back above the inguinal ligament. So the
yes,
hernia comes and goes back above the inguinal ligament. That's why it's called as a retort shaped femoral hernia.
Yes.
Now femoral hernia is more common in females or males?
So femoral is more common in females.
Why?
So due to the femoral canal anatomy.
Well, what is anatomy? How is it different in males and females?
So it's due to the pubic bone is it's more like it's more obtuse down. So there is the femoral canal is larger, and the
larger in males or females?
Larger in females.
Why?
Due to the pelvic anatomy, sir. The pelvic
the
bone.
wider anatomy. It is, the narrower the space in the femoral ring canal, right? Okay, simple. Go read up on the boundaries of the femoral ring. Three of them are bounded
by the lacunar ligament, the inguinal ligament, the iliopubic tract, and the femoral vein.
Correct. The femoral vein, simple, common sense, according to me. See, three of them are boundaries which can't stretch. They're rigid structures.
Yes.
The ligaments. The only one which can is the vein. Do you think the veins are bigger in females or bigger in males?
Bigger in males.
Correct. So if it's a smaller femoral vein, there is more space for the hernia to come out. That's how I look at it.
Okay.
Correct? Much more simpler and easier way to understand. Okay.
Yes.
Now you've told me something about a globular swelling. Why are you so particular about a globular swelling?
Sir, to differentiate it from a indirect swelling, which would be pyriform.
Correct.
Indirect hernia.
Why?
And so pyriform, since it's going through the internal ring into the through the external ring, so it's it will have a narrow neck and a sac in the end. So.
Correct. You'll have a small extension of the hernia which goes above towards above the inguinal ligament. Okay.
Yes.
Now, gurgling sound on reduction, is that why do you think that's important?
So it would differentiate the contents of the. So in case of an enteroseal, there would be gurgling sounds on reduction. And if it's omentocele, it wouldn't have it.
Why will you have gurgling sound in the intestine, first of all?
So due to the gases present in the intestine, so
Yeah.
when on reduction, there would be.
It's basically a mixture of gas and water which gives that gurgling sound. Okay.
Yes,
What if there is no gas in the intestine?
then there wouldn't be gurgling sounds.
Okay. So
Yes.
follow up to that. Is there any other way you can differentiate between omentocele and enterocele? All theoretical. None of them we are going to do practically, all theoretical.
Sir, omentocele would be easier to reduce initially and difficult in the end. And
Okay.
enterocele would be more difficult to reduce initially and then easier to reduce in the end.
Can
And
you care to
and
explain why?
sir, in case of omentocele, the initial part would be easy, and the second part would be difficult due to adhesions formed between the omentum and the
Correct.
opening. And in case of enterocele, due to the
Not
gases
the
and
opening, it's the sac. If it's with the opening, it will never reduce.
yes, with the sac,
Okay.
there would be
Sac.
yes,
Yeah.
yes. And
Any
in case of
simple test. Any the simple test to differentiate already.
sir, yes, sir, on percussion there would be a resonant note in case of enterocele.
Okay, anything in palpation, you already mentioned.
So the consistency is also important. So the doughy inconsistency in case of an omentocele, and it'll be elastic and consistency on for the for
Okay, do
enterocele.
one more follow up to that question.
Yes, sir.
What are the three types of consistency?
So soft, firm, and hard.
Then where does doughy come into picture?
So it's a term used in this one. So it'll be firm, I guess. No, it's
No.
soft to firm.
Yeah, just leave it at soft. No, simple.
Yes,
Okay. All that is all this is just theory. Now the
yes,
fact that you're
Because
putting
such a
doughy
overlying skin is there, okay, thick skin, and you can't
Ah.
really make out anything.
yes,
Some
yes,
nodularity you can make out if there is a
yes, a granular.
granular, okay. Whereas
Yes,
in the soft, smooth surface, you can get it in the if it is a intestine. Okay.
yes.
Yeah. So can you tell us how do you perform a deep ring? Okay, just and follow up to this. Where else will you find doughy consistency? The terminology.
The classical description of doughy abdomen.
You mentioned something in your past history or medical history.
Doughy abdomen. Feel you get in.
So I'm not sure. So.
There is a capital of.
Abdominal
So
tuberculosis.
obesity.
Abdominal tuberculosis.
Okay.
Okay, very complex topic for you guys. Will not get into that. There are various types of abdominal TB. Let's not get into that. But so don't get into the doughy consistency. If you
Yes.
want, leave it at soft, firm, or hard. Let the
Yes.
examiner ask you. Don't put something that you will give them ideas to ask questions like this. Then questions will
Yes.
start on abdominal tuberculosis.
Yes. Yes.
Okay. Yeah. So how do you perform the deep ring occlusion test? Standing or supine position?
So we reduce it initially by lying down, and then we occlude the deep ring by like placing our finger horizontally or along the path of the inguinal ligament. And then we ask them to stand and ask them to cough. And if swelling is seen medial to the side, then it's a direct hernia. If there's no swelling, then it's probably an indirect hernia.
And that's the end of the test? The second part of the test is to remove the finger and ask him to cough to see if this hernia comes.
Yes. Yes, sir.
If the hernia doesn't come only then?
So the hernia?
You have reduced the hernia.
Yes, sir.
Now you put your finger and ask him to cough, it's not coming.
Yes, sir.
You remove the finger, it is still not coming. So how are you so sure your diagnosis is correct? See, okay, let us say the opening was narrow. Somehow it had come outside. You have forcefully pushed it back and it's not coming out at that point of time.
Yes, sir.
Okay, so it can still be a indirect inguinal hernia.
Yes, sir.
Okay, so you have to perform the second half of the test where
Yes.
you lift your finger and ask him to cough and see if the swelling comes.
Okay. Yes.
If it doesn't come, okay?
Yes, sir.
Done. And you told something that you have to keep it horizontally. Why horizontally? Why not vertical?
So because the shape of the deep inguinal ring.
Is a U shape. So
Yes,
which is
yes.
the shape of your horizontal thumb. So if you keep
Yes.
it straight, there is a chance the hernia can slip underneath your finger on the side and come out.
What are the fallacies of deep ring test? Its question is, they'll ask
So
you.
one is if the deep ring is way too large, then it maybe cannot be performed since the swelling could still go through. And another is in case of a pantaloon hernia also, it'll give a false reading.
Very good.
Excellent. Okay. And Siemens test. Which are 3 fingers you're going to use?
So the index, the middle, and the ring fingers.
Where you keep which one? Which
So
hand you right side?
since this is a yes, so this is a right-sided case, we use the right hand, and then we place the index finger over the deep ring, the area of the deep ring, which is the half-inch above the mid-inguinal point. Then we place the middle finger over the pubic tubercle, and then the ring finger is placed at the saphenofemoral junction, which is 4 centimeter lateral and below the pubic tubercle.
What's saphenofemoral junction? What are you telling? One is deep ring, one is superficial ring, one more is a femoral ring. Okay.
Yes, femoral.
Saphenofemoral junction is different from this ring, femoral ring.
Yes, yes.
Okay, saphenofemoral junction is 1 centimeter above the femoral ring. It's not at this thing. And
Yes,
your superficial ring is 1.25 centimeter above the pubic tubercle. So you tell the 3 rings. You keep on the 3 rings. One is the deep ring, one is the superficial ring, one more femoral ring. 3
yes,
things like this.
yes.
Never write this middle finger, index finger. What? How do I know you don't have an amputated ring finger and you're using your little finger for the test? Okay.
Yes.
Always say impulse felt at superficial ring.
Superficial
Impulse
ring.
felt at
The
deep
inference
ring.
is like that, yeah.
Impulse felt
Yes.
at femoral ring. You tell
Yes,
it.
sir.
Let them ask you
Yes.
where are the 3 rings. Then you tell them the surface marking what you just told us.
Yes, sir.
Okay. Not at FMAS. We are only bothered about direct, indirect, and femoral hernia.
Femoral. Yes.
Okay.
Yes.
Yeah. No, and second thing is this deep ring occlusion test, what you said, you don't have to make the patient stand. Lying, let the impulse reduce, put your finger and ask them to cough and look at the bulge.
Yes, sir.
Only if it doesn't come out or you
Then
think
we can.
doubtful, then make them stand because there will be increased intra-abdominal pressure.
Yes.
Okay. And second thing is on standing, sometimes in females, a femoral hernia will become a lot more obvious as against lying down. That is
Yes.
added advantage of making them stand, but that I said is after you have examined them in supine. By the time you keep their finger in the groin, make them struggle and get up, your finger would have moved off to somewhere else.
Yes, sir.
Okay? Yeah.
Yes.
Next slide. Dull note, no vowel sounds. I'm sure you're all ready for that answer. Okay. One thing I have in this, you have mentioned that there is a single linear scar present parallel to the left inguinal ligament around 4 centimeter in length.
Yes.
Do you think that is sufficient?
Sir, it should ideally it should be an incision in the along the medial 2/3 of the inguinal ligament. The skin
No,
incision.
simple. I'm asking you a simple common sense. Forget about all that. What is the length of the inguinal canal?
So it's a 4 centimeter in length.
Okay. And
Yes.
your mesh is only up to the inguinal canal, or do you go beyond the inguinal canal and put the mesh?
Beyond, sir.
So do you think a 4 centimeter incision will be enough?
No, sir.
Because you have to go up to the deep ring, beyond the deep ring and put the mesh and come, right?
Yes, sir.
So invariably it will be slightly longer than that. But of course, people will say the skin is stretchable. I pull it this side, that side and do it. But
Yes.
Practically better to avoid the 4 centimeter word. Just say
Yes.
that there is a groin crease incision or whatever you mentioned here, that it is parallel to the left inguinal ligament. The scar
Yes.
seems to be healthy. There is no obvious swellings or cough impulse felt in the left groin.
Yes.
If you have a hernia on the left side, where do you think is the most common side with after surgery? Sorry.
So usually the medial aspect.
Why? Because that is where technically it becomes challenging because you are anchored it to the pubic bone, but
Yes.
there is a small gap between the rectus. Okay, the rectus muscle which comes and the edge of your mesh. So your mesh has to go onto the rectus muscle and cover it. Okay, rectus abdominis, the center muscle, right?
Yes, sir.
There is a small gap, the hernia can creep in through that space. That's
Yes,
the
sir.
reason why you have the risk of medial recurrences is much higher in a hernia. Next slide. Why were you bothered about per vaginal and per rectal examination?
So, like per vaginal examination, I checked again if there's a cystocele, if like to check for a cystocele or anything, in a prolapse, or and then per rectal examination again, if the patient had presented with constipation, then we would have to check for any
What?
strictures or any carcinomas or anything as such.
Whoa, okay. If it's a carcinoma, she would have come with you come to you with a
Yes, sir.
carcinoma, not with a hernia of 6 years or 7
Yes,
years.
sir. Yes,
Okay.
sir. Yes.
For sake of completion, yes, I do accept what you said, but don't get into that carcinoma janjat. I would have probably left this out because it's a
Yes.
female patient. If it's a male patient, definitely yes, because you're looking at prostate in an elderly
BPH.
male.
Yes.
Okay.
Yes.
Kishan, your thoughts on this?
Yeah, correct. Any straining factor, but okay. But again, yeah, you just look at the patient and what you are dealing with. In a abdominal examination, okay, fine. In a hernia, and when there are no symptoms, unnecessarily mentioning all this which are irrelevant, make no sense. Okay.
Yes.
Yeah. Next slide. Systemic examination, yes, Carnet's test. Why do you think that's important? What do you mean by Malgain bulgings?
Sir, Carnet test would basically it's to check the tone of the abdomen. So, Malgagny bulgings are like if the tone of the abdomen is low, there would be certain like bulgings present on the lower lateral abdomen, usually over the medial two-third of the inguinal ligament.
Which basically tell you it's a weak muscle. So
Yes.
what is the implication on the treatment?
Like wall strengthening would be required.
No. Okay. Simple. We'll keep it at this. You have heard of Bessonese and Scholdi's repair?
Yes, sir.
And you have heard of Lichtenstein's repair?
Yes, sir.
What do we do in Bessonese and Scholdi's? Roughly.
Sir, it's the muscle strengthening repair, sir. So
You
the
just pull down the
posterior.
muscle and you suture it
Yes, sir.
and try
Suture
to
it.
obliterate the canal.
Yes.
Whereas in Lichtenstein's, what are you using?
We place a mesh, sir.
Mesh. Now, if a patient already has a weak muscle in the form of Malgain bulgings,
Yes,
would
sir.
you prefer to do Bessonese or Scholdi's when you know the muscle is already weak?
So we'll go for mesh repairs.
That's all. That is the idea. Okay.
Okay.
So there are certain anatomical repairs. Now there is something called Desarda's repair also. So
Yes,
whenever you have these
mesh.
Malgain bulgings and all, always preferable to go for a mesh repair rather than a anatomical repair.
Yes.
Okay. Divarication of recti, where do you see it?
So we see it in the epigastric region.
Yeah, so it's kind of far away from your side, not very
Yes.
important, but I do take your point. Okay, that it basically means the patient is very weak or
Yes.
weak muscle tone. It's more of
Yes.
stretching rather than weak muscle tone.
Yes, sir.
Divarication. It's the linea alba which gets stretched out. So it has nothing to do with muscle tone. It's basically with a lot of obesity where the abdomen gets stretched gradually over time.
It's mainly
Yes.
important in umbilical hernias. Okay, umbilical hernias
Yes.
is because you just many times it's missed even in the scanning also. They just give umbilical hernia and you just do hernia repair and they'll come with a recurrence because there is a many a times this divarication of recti is missed. Okay, so you have to cover a bigger space with the mesh than just covering up the umbilical hernia defect. So that's where it becomes more important. Okay, umbilical hernia.
Yeah.
That's sir was telling about the stretching of the already weakened umbilical cicatrix. It's already weak. It's in a pregnancy or abdominal increased abdominal pressure. It is opens up. So along with that, even other muscles also surrounding muscles also may stretch up and cause divarication of recti. Yeah.
Yes, sir.
Next.
Why have you mentioned visible peristalsis?
Sir, again, for any obstruction symptoms could lead to visible peristalsis.
No. Okay, now that is a bit too much, but again, I would like to reiterate myself. You will not get those patients as your clinical cases.
One thing, and it's not must Dhruv to fill up so many just to make your case look bigger or something. You need not have to fill all unnecessary, irrelevant things. Okay, if it's relevant,
Yes.
relevant for your case, what is relevant, just write 2-3 sentences enough.
And I would have actually preferred you to write these Malgain bulgings in your local examination itself.
Yeah.
And then in your
hernia,
inspection,
what's
mention it
important
there.
for us is any distension is there. Okay, like SRTs or anything. Second thing is this thing. What is that? Any muscle tone. That's all is important for us.
Yeah.
Yes.
And in a respiratory examination, what else is important?
So again, to check for if there's any so respiratory.
This patient is asthmatic, no?
Yes, sir, but
Yeah,
there's
added
no
sound.
findings on respiratory examination.
That's all. Okay.
Yes.
Rather, after you've written normal vesicular breath sounds, you have written so many unnecessary things, right? Here, this is actually necessary. You can go on to mention that there were no added sounds.
Yes.
Yeah. Next slide. Okay. CNS, CVS, okay. Don't go into that inguinal lymph node business, please. Please take it off.
Yes, sir.
Okay. What sort of hernia case do you expect inguinal lymph nodes to come? All that issues will start.
Yes.
And second thing is, in summary, the first line I've already given the diagnosis. That is not a summary. You have mentioned it's a hernia.
Yes, sir.
So in summary, you're just summarizing your findings. You're not diagnosing the patient.
Yes, yes.
Okay. So rest of it is okay. That there's a 6 into 6 centimeter size with expansile cough impulse. That is missing. That has to be the first one.
Yes.
One paragraph from the some history, one paragraph from the examination you will include. No diagnosis or anything. Okay, just the findings from your history and examination you will include in the summary.
Okay,
Yes,
with deep ring occlusion test, suggestive of no suggestive, just this much, and you stop it there. And next slide, you move on to your diagnosis.
Yes.
Yeah. So can you go to your diagnosis? There's one point missing in your diagnosis.
So complicated or uncomplicated?
Oh,
Yes, and one more very important.
Reducible itself means uncomplicated.
Reducible is there.
Oh yeah, that's there. Yeah, but I would still prefer you to write complicated or uncomplicated.
Complete and incomplete.
Yes.
So since it's a direct hernia, I didn't think it was.
But do mention it.
Yes.
Long-standing, even direct hernias also can come up. Okay.
Do mention it. But I do take your point. I do take your point. I will find out what the examiners nowadays
6 points
like.
in hernia diagnosis. Any exam look up for 6 points. What I tell? Right or left?
Right or left. Then if it's complicated or uncomplicated.
No. Come step by step. Complication comes later.
So
Next.
then direct or indirect.
Before direct.
So the region, sir,
Inguinal or femoral.
Femoral. Yes.
Once it is inguinal, only then comes the
direct or indirect.
Direct or indirect. Then if it's indirect, then
so reducible or
complete or
complete or incomplete.
Incomplete. Then any associated complications. Okay, irreducibility, obstruction, anything. Then the 6th point is possible content.
Yes.
Okay. Under these 6 points on, and most of the questions will be based on this only. How you say it is inguinal, not femoral, and how you say it is reducible, not irreducible. How will you say? Okay, each point you have to substantiate at the end.
Nishanth, can you elaborate what that PM3 is?
Sir, it's the European Hernia Society classifications.
P is for primary.
So P is primary and MS for medial and
medial to what?
So it's a medial hernia, sir. So it's a
medial
direct,
to what?
The pubic tubercles.
Right.
Inferior epigastric arteries.
Inferior epigastric arteries. So anything medial to inferior epigastric arteries are direct. And what are the 3?
So it's more than 2 finger breadths in size.
What is more than 2 finger breadths in size?
So the size of the hernia, sir.
Not the size of the hernia, the size of the defect.
Yes.
So that should not come in your diagnosis.
It's an ultrasound.
Yes.
It's an ultrasound finding. Okay. Or after you completely reduce, if you put your finger there, now if you put this, you're contradicting your statement of using one thumb to block the deep ring.
Yes.
If it's more than 2 finger breadth, that means 4 or 5 centimeters. Your finger might not be sufficient enough to block it.
Yes.
Okay. Now the alternative for finger breadth is 1.5 centimeters, 1.5 to 3, more than 3 centimeters.
Yes.
Okay, because the fingers can change, right? My finger and your finger breadth might not be the same.
Yes.
Done. So moving forward, how do you proceed?
So hernia is more of a clinical diagnosis. Ultrasound can be done for like contents, but not very necessary. Then since like we can get a chest X-ray for this patient.
Forget about all that. First, confirm your diagnosis. You have told me it's a clinical diagnosis, but I would still ask you to get an ultrasound done. Why?
To confirm the defects.
No, I'm not worried about it. Whether whatever is the defect size, my surgery is not going to
He's a
change.
laparoscopic surgeon, man.
Yes.
I'm giving a clue.
Sometimes small femoral hernias can get missed.
Okay. Yes.
So you might as well have a look at it. All right. That is for the female. What about male?
So male, like ultrasound can be done to check for benign prostatic hyperplasia, which is usually transrectal ultrasound.
Hey, no. You don't have to probe everybody in the rectum. No.
And one more thing is,
Yes.
when you are doing especially laparoscopic control, some associated problem may be there that you have to know and give a option to the patient. Okay, see, you are also having this again, doing another surgery for that may not be substantiated. So get an basic investigation of the abdomen and that part and once, and if there is concomitantly any other unknown some pathologies are there that you have
Mass in the abdomen.
Yeah.
Some undiagnosed mass in the abdomen might get picked up in the ultrasound, because that itself can be a cause for hernia to be, that can be a risk factor of the hernia.
Yes.
Okay. So you have done this. Okay. Then you want to get a chest X-ray done. Why?
So again, like to evaluate the patient's respiratory health, in case of anesthesia and all, it will be necessary.
More
If we
than
have to go for
anesthesia?
surgery.
Okay, anesthesia, fine. Then anything
Then
else?
laparoscopically would not prefer to do in case
Why?
of. So since we
I get
are
offended if you say stuff
CO2
like this.
sir, insufflation will be done, sir. So if respiratory condition is like
No.
impaired, then
It's not just about the anesthesia or the surgery. What is your more, as a surgeon, what you're more bothered about? What you're more bothered about? In any hernia case?
oxygenation, healing, and
Huh? No.
healing would be.
Okay, healing. Okay, agreed. Except they're on corticosteroids, so
Yes, sir.
immunity is little. I agreed. Anything? Yes, Raghav is right. See, he's telling recurrence. Now you tell me how. Without controlling the cough, if you do a surgery,
Yes, sir.
tomorrow
It
if
will
he
be
starts
continuous
coughing
increased
violently,
pressure.
all your teachers are going to give away. So first
Yes,
you have
sir.
to control your asthma. If it's a smoker, you have to stop the patient, tell the patient to stop the smoking beforehand. So control everything. So in any case of hernia, it's very important to know the etiology first and correct it. Then only go for the surgery. Surgery is not an emergency in hernia. If you hurriedly do the surgery, then they will come with recurrence. Clear?
Yes.
So whatever you told is all valid, but most importantly, as a surgeon, what I am worried about is the recurrence.
Yes.
Not the healing and all. Healing 7 days or 14 days, it will heal eventually. But if it recurs, no, it's very bad. Laparoscopic, then you have to go for open surgery, or if you do again, you have to go for laparoscopic. So again, like you said, if the respiratory the efforts are not good, GA may not be able to give. Like that, so many problems arise.
Yes.
Clear?
Yes, sir.
Nishanth?
Yeah, that's it. Nothing extra to add. So, okay, you said chest X-ray, then fine. What else will you do next?
Sir, complete blood count and
all those again for the anesthesia point of view, because the patient has to be fit for surgery. What surgery would you like to perform?
Sir, a mesh repair, it's like in the intention-free mesh hernioplasty.
What are the possible alternatives?
Sir, in case of direct hernias, we can do the muscle strengthening surgeries, all the Bessini shoulders, then Desardano mesh. Then
This is an 80-year-old female.
Yes, sir. We would
Sorry,
prefer
60-year-old
SR.
female. The muscle strength will be low in these
Oh,
patients.
yes, sir. Yes, sir.
So
Mesh should be.
preferable to use a mesh repair.
Yes, sir.
Okay. Why not laparoscopic surgery?
So again, respiratory functions, since we are insufflating either the abdomen or the space that we are creating during TEP, it would lead to it would be difficult for the anesthesia, like in anesthesia point of view, to
Oh,
maintain a
yeah.
GA.
I will not get into the depth because you guys are not exposed to all that. Once you're exposed, probably in internship and all, your view might change regarding laparoscopic surgery and hernias. Just to give you a food for thought. Now, if the patient had acute cholecystitis, the same patient with asthma, you will do open cholecystectomy or laparoscopic cholecystectomy?
So laparoscopic.
Why the sudden change of heart here?
Yes,
For hernia, you want to open surgery?
yes,
Okay, yeah. So that doesn't mean just because they have an issue. Of course, for undergraduates, the idea is do laparoscopy whenever there's a bilateral hernia because the incision will be small and you can repair both. And whenever general anesthesia is not a contraindication. For you
yes.
guys,
Bilateral or recurrent.
For see, there is called step and all, total extra peritoneal. There we don't
Yes, sir.
insufflate much and all. So can be done
Yes.
safely. Okay. Like for undergraduate, okay, what you told is I agree. For undergraduate level, okay.
Yeah.
One of the, when their patient is not fit for general anesthesia like respiratory, why to take risk? But now an indication for your level, what you should know is for
In bilateral or
was
recurrent.
mentioned, yes,
maybe.
bilateral hernia and recurrent hernias. Indication
Yes.
for laparoscopic.
For
Okay.
laparoscopic.
Yeah.
and rider to that is recurrent has to be from the other side. Okay, like if they're done open hernia and recurrence is there, laparoscopy. If they're
That's
done a
what I told.
laparoscopy and there is a recurrence, do an open hernia.
Okay.
But
Virgin
again,
space.
Yes,
yeah, all this is for undergraduate level. But if the examiner asks really, then say not necessary. If there is a laparoscopic recurrence, you can do it laparoscopically. If your challenge, your technique and all is good and you're very well skilled, you can repair it laparoscopically. Open hernia also, if it recurs and the patient is very sick, you can't give general anesthesia, means you can do a open hernia and only close that hole.
What the understanding you should have is always a virgin space is better than a already used because all the entire
Yes, sir.
anatomy or
Additions
distorted,
would be-
all the layers would have gone. So more chance
Yes.
of injuring the structures like the cord structures, all those things more because everything will be messy there. Okay, you can't differentiate which layer is what and also it is better to go for the virgin
I'll give you an
spaces.
actual example. I'm operating on an elderly gentleman tomorrow. I'm doing an open inguinal hernia for him for a
Yes.
recurrent open inguinal hernia repair. Okay,
Yes.
that's because he's very bad asthmatic. He's on inhalers like some 7 or 8 times in a day. He will not tolerate general anesthesia. So I can't do laparoscopy for him. Okay. So even though
Yes.
it's open hernia procedure that is being done and recurrent, I'm forced to again do an open hernia repair. Okay.
Yes.
But like I said, for undergraduates, keep your mind open if the examiner tries to negate what you're saying. What we told you the first one, if it's open, do lap. If it's lap and recurrence, do open. But the examiner
Yes.
says, are you sure? Sir, this also can be done in certain special scenarios.
Yes.
Okay. Done. Anything to add, Kishan?
What are the complications of hernia surgery?
A mesh
Sir,
repair. Let's say the patient, you have done a mesh repair. What is the most common complication?
sir, like during the operation, intraoperatively, there could be hemorrhage or anything, and then
Not anything.
sir, like there could be like
Operatively, only
ilioinguinal
two
nerve
things can
damage
happen.
or
One is injury to that inferior
the
epigastric
nerve
of
and
the femur. You can injure, especially while placing the mesh to the inguinal ligament. You can underlay
yes,
there is the inferior epigastric. So bleeding can occur. Second
bleeding
thing is
and
injury to
nerve
the
damage.
nearby structures. What are the nearby structures?
Sir, nerve damage can happen. Ilioinguinal nerve. Then
Then damage the cord structures only, no?
yes, sir. So yes,
Yeah, you can damage the cord structures. If you're trying to open the sac, right? Let's say
yes,
it's
sir.
indirect hernia, it is within the
Round like
spermatic cord. So you have to
yes,
open that what we call as a cremastric box because the cremaster muscle which is surrounding the cord structures. So when
yes,
you're
sir.
opening that, you can damage. You can.
Here,
Okay,
here
of course,
is
this is a female.
Nishant.
Yes, sir. But female patients. Yes.
Yeah.
In this patient, okay.
In this patient, fair enough.
Okay.
Sorry.
Yes.
Okay. Next, what other complications?
Sir, then afterwards there can be hematoma formations, then seroma formation.
Seroma.
Then there could be like the mesh could cause ilioinguinal nerve compression symptoms, or like mesh inguinodynia could be there. Then
For that, what we can call.
What is the definition of inguinodynia? After which point do you start calling
So
it inguinodynia?
after 3 months we can say it's inguinal.
Excellent.
Chronic.
Excellent answer.
Correct.
For
Yes.
that, what can happen? Exercise can happen. Okay.
Yes, sir. Yes.
Then what later on? You say intraoperative, immediate postoperative,
Recurrence
late
also
postoperative,
can-
what can happen?
So recurrence can happen. Then
Okay.
yes.
Anything else?
That's it. Well presented. We have covered a lot of information. Of course, there's a lot more we can go into depth and all, but
any laparoscopic approaches and all you should know as an undergraduate. Okay, what are the
Yes, sir.
laparoscopic
Tap
approaches
and
you
touch.
have?
Yes.
Tap and tap you should know, what at least basic, and the triangles you should know. It's a theory question
Yes, sir.
also for you. Okay, there are good videos by Nishanth in our this thing, so you can see them. Okay, laparoscopic anatomy of you should know, and what's more important is about the meshes you should know at least what
Yes.
what's it
material.
Yes, sir.
What
Yes.
is the material? What is the nature of the mesh? What are the pore sizes?
How it
Yes.
really acts also. Okay, and mainly
Yes.
for an undergraduate, what is important is to differentiate between 3 types of surgeries. What's herniatomy, what is herniorrhaphy, what is hernioplasty. Should be able
Plastic. Yes.
to tell. Okay, what is herniatomy, rhaphy, and plasty. What is the definition of each?
Yes.
Okay.
Can you tell us what is herniatomy, Dhruv?
Otomy.
So in herniatomy, we are so after we open up the layers, we excise the sac, and then we push the contents in, and then we just we just twist the sac, and probably with an absorbable suture we can tie the area, and then just close it back up. So in case of like in younger patients,
Close
we
what?
close back the abdominal muscles, the aponeurosis.
See, this is a sac. Dhruv, this is a
Yes,
sac.
sir.
Okay. You open the sac.
Yes, sir. We push the contents in.
Herniatomy, and you put the content from the proximal sac. You put all the contents inside, and
Yes.
then you don't tell absorbable, non-absorbable, all these things. All the very like individual depending on the surgeon's priorities. Okay, using a suture, you just close this end, the proximal end,
Yes.
so that the contents will never come back.
Yes.
The distal
And
end you
then
cut and you keep it like that.
yes.
The scrotal side. Okay. So opening a cavity and closing it, it's called otomy. Herniatomy.
Just to add on to that, Dhruv, herniatomy is done only for children. That is because in children, the superficial
The obliquity could
overlay each other. So the sac
Yes.
is coming out and going back in, right?
Yes.
So whatever has come out, you remove that, push it back inside, and you're not doing anything to the ring. You're not
Yes.
closing the abdominal wall. That is what I want to correct you. You kept saying, we'll close the abdominal wall. No, you have not opened the abdominal wall.
Yes.
only
The
Gradual
skin and
stage
vaginalis.
superficially. Yes. Yes.
No, you're not opening anything. You're not even open. There is no inguinal canal.
Yes.
Inguinal canal forms only when these two move away. That is when this path becomes the inguinal canal.
Okay. Yes.
In a child, both of them are one over each other. So
close.
there is no canal at all. So you have
Okay.
never
Well
opened the
developed.
external oblique.
Yes.
Are you understanding the difference? Here you're only cutting the sac which has come out, closing it and pushing back in and leaving it. Then gradually as
Yes.
age progresses, these two rings will go far away and there is no hernia.
Yes.
Okay. Herniorrhaphy is your Bessenes and Scholtes repair where you open up the superficial ring, that is the external oblique.
Repair.
And then tighten the posterior wall and then suture the external oblique again.
Yes.
Okay. And the last one, hernioplasty, is where you put a mesh and allow fibrosis to happen.
Yes.
So remember in herniatomy, it is only the sac. You're only excising the sac and nothing else, and you're stopping and you're getting out.
What is that
Yes.
sac actually?
So
What is that
It's
sac?
it's
Process
patent process of vaginalis.
vaginalis. Okay. Whereas in direct hernia, you don't open the sac.
Yes, sir.
Direct hernias. Okay. You push it inside
We just
and
push
do
it back and
you can do the roughy or plasty. Okay. Roughy
yes,
means
sir.
repair. Primary repairing with suturing is called roughy anywhere. Okay. Plasty
Yes, sir.
means what is it? Recreating the abdominal wall. It's called plasty. Okay, you with the
Yes, sir.
prosthetic. Okay, now just now I mentioned all the fibroblasts will grow, granulation tissue will grow over that mesh through that pores and create a new wall there. That's plasty. Hope it's clear. Okay,
Yes,
different named different, so many types of hernia repairs are there. You should know what is
yes,
NIHA repair. And some classifications are there. You should know. Okay,
yes,
classification of hernia other than EHS. And third thing is one more is Nishanth. Steps. Okay, what are the layers you should know? What are the layers of what they were that skin, campus, scarpas,
campus, carpas. Yes,
and
sir.
all those things you should know. Then
Yes,
anything, the contents of the cord, all basic anatomy. Inguinal hernia is all about anatomy. Inguinal anatomy you should know. Okay, what is Hasselback
yes,
triangle? Okay, all
yes,
those things. Yeah, one more thing. What I was telling is named hernias. That's one important topic. Okay, UG level they'll ask you what are the
yes,
different named hernias. What's
yes, sir.
Amyant hernia? What is Litters hernia? What is
Yes,
so many.
medals and yes,
All
sir.
those things you should know. Okay, so important for your entrance. These days they don't ask that kind of direct questions, but it's good to know. Okay.
Yes,
Nishanth, anything? Any doubts you have, you can ask Nishanth directly. Raghav, Abhimanyu, so many active members. You can ask Dr. Nishanth if you have any doubts or hernia expert. So if not, concluding remarks. Concluding remarks from. See, he only told no Dhruv, only experts does recurrent surgeries.
yes,
Okay,
Yes or no?
just coming to a point, not to burst all of your bubble. Does any of this actually matter in the treatment? So much we have learned in provisional diagnosis, all this. Does it actually matter?
no, sir.
Whether it's
The
direct
repair
or
is the same.
indirect, the surgery is the same.
Yes,
Whether it's enterocele or mentocele, the surgery is the same. So whether it is femoral or what is that, inguinal also, the surgery is the same. Because the mesh what you're going to put will cover the direct, the indirect and the femoral ring. Okay?
yes,
So
yes,
honestly, whatever we have done till now doesn't matter as long as you know it's a hernia. The only thing I do in the OPD is see if the patient has cough impulse, take him up to OT. That's all.
yes,
Okay. Then there's a question. If recurrence occurs after both lap and open, what to do? This is a choice between your comfort and the patient's comfort. I would prefer to do a laparoscopic repair because I'm a lot more comfortable and you get to see the entire anatomy from the inside. Okay, you have a lot of space, wide area. But in open repair, I'll have to increase the size of my incision that big to look at all that area. So I would prefer to do a laparoscopy, but that there is no correct answer to it. You can do even an open approach as well.
Any other doubts? So, yeah, Nishanth, concluding remarks about the her topic and the presentation, please.
Excellent presentation. Very well presented, Dhruv. I was really impressed with your presentation and the level of answering and the way you have understood the topic rather than anything else. I would have
yes,
blindfoldedly given you a distinction. Okay. But of course, few small changes here and there, like I told you, don't get in this presentation. What is a distinction level presentation can suddenly drastically turn to something else the minute the examiner decides to go off course.
yes,
Like I said, Dovey abdomen, the minute he goes into intestinal TB, you're gone.
yes, sir.
Okay, the minute you go into strangulated hernia, you're gone. Then they'll start asking anatomical repair, what will happen, what will you do, where all you'll use biological mesh. It can just take off in a tangential direction. So
Yes,
you yourself think like an examiner.
yes,
If I've put this point in my paper, if I'm going to say this, what are the possible questions and do I know the answer? I'd rather not write it at all.
Correct.
yes,
Okay, and take him in a direction where I know what the answer is.
Yes.
Even small words, no added sounds mean I know the next question will be what are the added sounds? I should
Yes.
know the answer for it.
Yes.
Otherwise, I just say no V's or wrong and I leave it. I will not write added sounds.
Yes.
Okay, so these are small things that you need to pick up. That's all.
Yes.
And about the hernia, anything you want to or conclude?
Nothing much. It's a pretty
Okay,
straightforward.
for undergraduate level, okay.
Yes, yes. Well done. Even for a postgraduate level, I would have been very impressed with the level of answering and the way I've understood the topic.
Yes.
See,
Thank you, sir.
Dhruv, having knowledge
Yes.
is something good, but application of knowledge is what is more important, okay, especially in the clinical practice. What Nishanth was referring to is 100% correct. So in the proforma or in the books, so many things will be there because it's given in general. It's applicable for all the patients in general. But when it
Yes.
comes to one index or individual patient, you see whether it's really important here, whether really relevant here. And see, you first take the history and do the examination, then come back, sit. Now you decide what is, you take the entire case, the story in one direction in favor of all your diagnosis only. No contradictory statements here and there, no unnecessary things like what Nishanth was telling. Okay, it's a storytelling, and you can tell the story in any way you want to the examiner. Clear? So you know, it's not like a conductor. He's telling something and you're writing immediately, and you can't change it anymore. No, you take entire case, do the examination, come back, and have a idea in your mind what all to write. Then think before you ink anything. Clear?
Yes.
So
Yes.
don't add anything unnecessary just to fill up the pages. That's what Nishanth was referring to. Hope it's clear for all our members. Wonderful presentation, I would say, Mr. Dhruv. Okay, your
Thank you, sir.
understanding is good, but you can still do better. What I felt is you can still do better. Okay,
Yes.
that's all. And hernia is a very important case for undergraduates, invariably kept in all the examination. Each one of you should know the basics. Anatomy is very, very important. Anatomy, all the anatomical aspects. If you don't answer the anatomy, gone. Okay, all the triangles, everything you should know. And second thing about that etiology or pathophysiology, how that intra-abdominal pressure causes the hernia, all those things you should know. And the basic hernia surgeries, you should be able to explain.